Well, I think the combinations are really the most important point here, which is these drugs will be approved as single agents, the newer generation FLT3 inhibitors, but I don't think anybody really wants to use those drugs as single agent as an alternative to chemotherapy. What we want to do is combine them with other drugs that are well tolerated and have activity to see if we can really maximize response rates and any survival benefits that the combinations might hold, and also move those drugs earlier into therapy so that hopefully we can prevent relapses. And similarly, knowing that adding midostaurin to intensive chemotherapy improves survival, one could imagine that adding a newer FLT3 inhibitor to frontline therapy might be really transformative. Now, we haven't proven that, but there are studies designed to test that hypothesis, either against a placebo control, as has already been started with quizartinib's phase 3 development, and due to the availability of midostaurin, that study is largely enrolling outside the US. But also there are studies comparing newer generation FLT3 inhibitors, the more potent and selective drugs, against midostaurin as the third drug added to frontline cytarabine and anthracycline chemotherapy. So I think we're going to get the answer off of that. And it's not limited to that combination in terms of the potential for FLT3 inhibitors. One could imagine that they could be added to many of the novel agency or sort of low toxicity agents in patients who can't get intensive therapy or for whom they've completed intensive therapy. And the question is, if they're at very high risk of relapse, can you continue therapy longer and, again, either prevent or push back a relapse? We're pursuing that question in the post-consolidation maintenance setting and also the post-transplant maintenance setting in ongoing studies that are randomized. And we have no data on that yet, other than it seems to be feasible. If you take a drug that's relatively well tolerated and seems to have clinical activity, it's something that is nice because you can give it pretty much indefinitely. And I've had patients on FLT3 inhibitors for years, long after they've gone into remission, just because they don't want to take a risk of relapsing. For the most part, these are patients who've had transplant and just want to do everything they can to avoid any return of their leukemia. And that's been a manageable approach for them.